Bismillah, Assalamu alaikum, greeting everybody. It's my pleasure and honor to be again at the Congress of Arab Thyroid Association. Thank you for the organizers for the invitation. The topic that I was assigned to talk about is the recurrent thyroid cancer management. This is where I work at Sheikh Shakhbout Medical City in Abu Dhabi, where I run thyroid cancer clinic. So when we talk about recurrence, we have to talk about the definition of it to begin with. There is a little bit of ambiguity between recurrent versus persistent disease. Perhaps the best definition for recurrence is when the patient was already classified as an excellent response to therapy after whatever therapy they received, surgery plus minus iodine ablation, then they had recurrence, then this is really the true recurrence. Otherwise, practically speaking, most of the what's so-called recurrences, they are not really recurrences. They are basically persistence of either microscopic or macroscopic disease. So if we look carefully in the patient's file, for example, the pre-op imaging, we could detect that there were abnormal looking lymph nodes from that time, but they were overlooked or not called, or some lung nodules on previous lung imaging, etc. Or if we look biochemically speaking at thyroglobin, we find that thyroglobin never became undetectable. So the patient really is, we are dealing here with persistent disease. And because of this ambiguity in definition, especially when we talk about just biochemical recurrence, when we have only thyroglobin being detectable, not structural recurrence, it's only biochemical recurrence, the definition is not clear, and that's why the prevalence of recurrence can widely vary in the literature if you look in the medical literature. Now, I'm sure you are familiar with this diagram that ATA published in their most recent guidelines from 2025. This is what estimates the structural recurrence rate at initially when you encounter the patient after the thyroidectomy the patient had. So according to mostly the pathology, histopathology data, you will classify the patient as either low recurrence, low intermediate, high intermediate, or high risk. And as you can see, for well-differentiated thyroid cancer, if it's low risk, then the risk for structural recurrence is less than 10%. It's between 10 to 30% for intermediate risk and above 30% risk for recurrence for high-risk patients. So here in my presentation, mostly we are going to focus about this type of recurrence, structural recurrence. I'm not going to talk much about other types of recurrence or biochemical recurrence. When we talk about structural recurrence, we will classify it to two categories according to the location. It's either local regional recurrence, mostly in the neck and the upper mediastinum where the thyroid was, and this is where most of the recurrences or persistence happen. And less commonly, the distant metastatic disease in the lungs, bones, and less commonly in the other locations. So to begin with, how to screen for recurrence, really the easiest, the most accurate, and the most cost-effective is biochemically by doing thyroglobin antibody, as well as neck ultrasound. This is very reliable with a caveat if the ultrasound was done by a reliable method. Because as you know, the ultrasound is technician dependent. So it's not uncommon if there is a possibility that there is something in the neck, but it's missed because it's not scanned appropriately. So this method is very sensitive in detecting recurrence or persistent disease as long as it's done by a reliable method and a reliable technician. It's not uncommon at all, unfortunately, that there will be a disease sitting somewhere in the neck and it's going to be missed. That's something I'm sure you have seen. I have seen personally in my own even institution where I work in UAE, in the US when I was in the US, etc. That's why, in my personal view, uh, the any thyroidologist should really do his or her own ultrasound, not rely on the technician. In my personal opinion, the ultrasound is like the stethoscope for the cardiologist. Thyroidologists cannot do optimal care for thyroid cancer patients if they don't do their own ultrasound. That's what I do, at least personally. Now, sometimes this will not be sufficient. We have to go to cross-sectional imaging, especially when we have a very elevated thyroglobulin, but we don't find significant findings on the ultrasound. Then it's the time to do CT scan of the neck, lungs, bones, etc., to look for other locations for disease. Diagnostic scan, especially with I-123, which is more sensitive than I-131, could be considered to look for recurrence, especially with intermediate high and high risk patients. Personally, I don't rely on this much because most of the time I find the source of the disease with structural imaging. In addition, cross-sectional imaging, I mean. In addition, the iodine scan is inconvenient to patients. They have to follow a low iodine diet for 2 weeks, then get the thyrogen injection. Some insurances may not cover the thyrogen. It's costly. And at the end, it may not necessarily give you good information. But definitely, if I do it and if it's negative, then I will not repeat it. PET-CT scan, especially if we have thyroglobulin rising very rapidly, or I know that the patient had originally some types of tumors that are not going to take iodine, they are aggressive histology like oncocytic or tall cell. Especially if the iodine scan was already done and it's negative, PET-CT scan will be helpful in this regard. So if we do detect recurrence, what do we do? We have different ways of approaching this. Active surveillance, believe or not, is the mainstay in many cases with recurrence. So we have to learn as doctors first and endocrinologists before educating the patient that it's okay to have cancer in our body. It's not going to necessarily be life-threatening. It's like having any chronic disease, hypertension or diabetes, perhaps even less riskier than having diabetes or hypertension. So if we don't feel comfortable ourselves as doctors, we will not, of course, be able to provide this reassurance to patients. That's why I am emphasizing that active surveillance is very appropriate in many cases of thyroid cancer, because we know how indolent the course that this disease follow. It's surgery, especially when we talk about local regional disease, surgery can provide cure. So if that something can be achieved, it's excellent. It's surgical disease. Iodine ablation treatment, when it comes to recurrence, in my personal view, it's something, it's really going down in my favorite list when I approach recurrence. This is different from initial treatment. If I have a patient just operated on and the patient is high risk or at least high intermediate, definitely I would do the iodine ablation. But when it comes to recurrence, it has really much less role in those patients, because remember, when we are dealing with a patient who already went through iodine ablation and yet still have the disease, then most likely then we are dealing with non-iodine avid. uh, and that's why it's not going to help to keep hitting this patient with iodine ablation. And the higher the dose they receive, the more harm will happen. We'll talk about that in more details. External beam radiation, sometimes we do it. Image guided techniques like alcohol ablation, RFA, is getting more popular, at least in my institution. We are doing it more often. And then systemic therapy. Important thing to realize when it comes to approaching recurrence, it's not as standard as the initial treatment, meaning there is no right and wrong answer. Patient may go to one institution, they get one advice, and go to another institution, their MDT will advise something else. It's all about weighing the pros and cons and then taking it from there. So active surveillance with TSH suppression, as long as the patient has stable asymptomatic disease, is appropriate. And when, even if we have suspicious lymph nodes in the neck that are small, less than 8 to 10 millimeter, then that's something doesn't necessarily require FNA, especially if they are not threatening any major structure in the neck, like the trachea, esophagus, and the great vessels. So this is an example. I would like to add cases in my presentation for illustration and to make sure that the presentation is not boring. So this is a case of a man recently underwent thyroidectomy with central neck dissection, and he underwent the iodine ablation. This is the first ultrasound I do after the surgery. And I find those two small rounded lymph nodes in left level 4, lateral to the jugular. They are suspicious. Potentially they have disease. They don't have fatty hilum, rounded, but they are small. Active surveillance is perfectly fine. Another example, a young woman underwent total thyroidectomy with right modified neck dissection as well as iodine ablation. First ultrasound I do on her, I see this 0.8 centimeter lymph node in right level 3, as well as hypoechoic lesion about 0.5 centimeter in left thyroid bed. They are small. I followed them. We went with active surveillance, and now it has been 2 years. They are not changing. They are, especially one in the right, it has microcalcification, probably the harbor disease, especially that the patient's thyroglobulin never became undetectable. But it's fine to follow those patients. Surgery, as we said, it's the one that can provide cure, especially when we talk about local regional disease. Should not be done unless if we have biopsy proven disease. So always we have to prove that there is recurrence, and then we act on it by doing surgery. Sometimes the location of the recurrence is so difficult to do the FNA, then we can go straight with surgery is in that exception, but in general we like it to be biopsy proven. And we do the biopsy only if the patient is going to agree to do the action or the intervention. If the patient is not going to agree on doing surgery or any sort of intervention, what's the point of doing the FNA, which is invasive procedure, of course. There are multiple factors will play a role in making decision towards doing surgery or not. The location of the malignant lymph nodes, as we said, they are threatening any major structures there. The patient's comorbidities, if there are many comorbidities not very fit for surgery, perhaps that patient is not good candidate for surgery, and we should look for either active surveillance or other options. The motivation and the emotional concerns of patients. I will illustrate a couple of cases how the patient's emotions and values played significant role in making the decision towards not doing any more surgery or intervention. Vice versa, if we are dealing with a tumor that's so aggressive and the thyroglobulin is doubling time is very concerning, and we know very high grade histology to begin with, or FDG avid on PET CT scan, with those patients that you want to push more towards surgery and interventions. Having said that, the ATA does recognize, even if the lymph nodes are bigger than 8 to 10 millimeter, that observation could be appropriate, could be followed in selected patients, and then surgery could be offered if progression happened later on. If the surgery is going to happen in the neck, then normally we recommend doing full full compartment dissection if that's not done before. Now, let's say if the full dissection happened already and we see, let's say, a recurrence in one lymph node or two lymph nodes and level 3 in the left side, then it's okay for just to do selective excision of those lymph nodes without full dissection, because the full dissection happened already and there will be fibrotic changes. So in that scenario, selective excision could be applied. And it's good idea always when we are talking about redo surgery to label the lymph node with either charcoal or methylene blue stain. That will make finding those lymph nodes during the surgery easier on the surgeon, especially if we are talking about significant fibrotic changes because of previous surgeries. Not easy sometimes to find those smaller lymph nodes. So this is an example that I want to illustrate about the patient's emotions and values. Very young patient. She had her original surgeries and very high reputation, well-skilled surgeon. She had lobectomy first in April 2020, then followed with completion thyroidectomy 4 months later, August 2020. Because of the findings that they found in the left lobectomy. That's why I recommended completion thyroidectomy. Then unfortunately, a year later, they found recurrence and patient underwent central neck dissection and left level 3 neck dissection. So far in almost 1 year, she had 3 surgeries and then had iodine ablation. And then in 2022, she was found to have this left level 4.8 centimeter lymph node that was proven to be cancer on biopsy. And that surgeon went in for the fourth time to try to remove it and could not find it, unfortunately. And the patient was so traumatized because of this. And she came to our institution, and I saw her for a second opinion. And she was like, "Please, doctor, don't tell me I have to go in for the 5th surgery." And I said, fine, let's watch it if you are comfortable with that. And we have been watching it, as you can see here, now 4 years between 2022 and 2026, barely changed this lymph node. Her thyroglobulin has been pretty much stable around 7. This is an example where the patient discussion with patient and their values and their emotions is very important in this in the recurrent thyroid disease approach. This another example of a young man. He's a nurse in our institution. He had left lobectomy in August 2024, 1.5 centimeter classic PTC, and he luckily remained euthyroid after the surgery. I saw him after the surgery for the first time. I did my ultrasound for surveillance, and I found this left level 4 lymph node, as you can see, rounded microcalcifications, very suspicious. less than 1 centimeter though. I explained to him it's very suspicious. It's very likely if I biopsy it, I'm gonna find disease. And if I do, then the recommendation will be is to do completion thyroidectomy and iodine ablation. And he said, if there is a chance to that we follow, that's better, because I know myself it's going to be difficult for me to take the medication of the thyroid. Nurses and doctors are the worst patients. So he said it's going to be difficult for me to take the medication on daily basis, and I'm still very young. I said, okay, let's watch, and you can see a year later, the lymph node pretty much stable in size, if anything, slightly smaller. So we have been watching it. Now, let's say this patient was not that reliable. I don't trust much that they will follow. Then I would have pushed more towards the surgery. But this patient is a nurse. He works in the same institution I work with. So I felt comfortable doing so. Iodine ablation. After surgery for recurrence, the use of iodine ablation should be considered as adjuvant treatment if iodine residual disease is known or suspected. I put question marks here because there are no studies showing the benefit of this approach, like after each surgery for recurrence to hit the patient again with adjuvant iodine ablation. There is no evidence that it helps the survival or decreases the recurrence in those patients. If the patient never received iodine ablation before, then yes, definitely the patient should be considered for iodine ablation. But simply just after each recurrence, after each surgery, to do iodine ablation, this is not something I would recommend doing. I don't personally do it. ATA says for isolated lymph node that's cancerous, that already received local therapy but did not respond, or local therapy is not feasible, then you can do iodine ablation. In that scenario, it's conditional recommendation, low certainty evidence. I much prefer the local therapy in this scenario, or active surveillance. If the local therapy is available, or active surveillance, I wouldn't do the iodine ablation, because honestly, my faith with iodine ablation for a disease that you see in your naked eye is so difficult to respond. I will give you an example in 1 second. So this patient, 34-year-old, underwent total thyroidectomy with right modified neck dissection for classic PTC. And I am emphasizing here on classic PTC, meaning we're not dealing with something known to be non-iodine avid. She did have iodine ablation. The first time she had 100 millicurie, then the second time 150 millicurie, so total of 250 millicurie. And you see her lymph node in the left thyroid bed, about 0.5 centimeter back in 2022. After that much dose of iodine ablation, it did not go away. It did not shrink. And in fact, on active surveillance, slowly, very slowly, it grew. And now it's about 0.7 centimeter. And it's because it started to grow towards the trachea. I just saw the patient last week. I recommended that we do intervention on her. The point here that I'm trying to make, that iodine ablation, this is why I don't have significant faith with iodine ablation. And that will, if this is for classic. Now, how about if we talk about the other types of cancers that are known to be less iodine avid, like tall cell or oncocytic cell cancer? Even now we have data that BRAF mutated cancers in general, they will take iodine less. And some institutions, they start not to do iodine ablation in those cancers. Empiric iodine ablation, we have two types of empiric ablation. Either if we have structural disease that's known on biopsy, but it's non-iodine avid on the diagnostic scan, we could do one-time empiric iodine ablation. Let's say if you have a patient with structural disease in the lungs and the iodine scan diagnostic is negative, we could do one-time empiric treatment. The most important benefit you find with this approach is a decrease in the thyroglobulin, but improved survival hasn't been shown, unfortunately. The other empiric treatment is for biochemical recurrence, that only if you have thyroglobulin detectable with no evidence of structural disease. The ATA says do not do it if the thyroglobulin is below 10, stimulated thyroglobulin is below 10, or after excuse me, or after withdrawal below 5. But if the thyroglobulin is much higher than that, then you could consider just for the thyroglobulin that's rising significantly. I personally don't do it just for numbers. I don't believe we should treat numbers. We should treat patients. So if I do empiric treatment, I only do it for structural, potentially non-iodine avid disease, if I do it at all. Speaking of non-iodine avid disease, it should not receive iodine ablation if we know for sure it's non-iodine avid disease. What's the criteria? This is evolving field. The ATA 2025 put this criteria for defining it. So when there is no uptake on post-treatment scan in settings of structurally apparent disease, or if we give the iodine ablation and there is progression within 6 months, then this is definitive criteria of non-iodine avid disease or radioiodine refractory disease. Again, here we are talking about post-therapy scan. Now, less supplemental criteria of less iodine sensitivity, so it's not completely iodine resistant. When we talk about diagnostic scan being negative, why? Because sometimes we find that when we give the high dose treatment on the post-treatment scan, there will be some uptake, and probably there will be some benefit in that scenario, especially in decreasing thyroglobulin, as we said. Also, when we have uptake in some, but not all, metastatic disease, so perhaps there are different stages of differentiation. So the ones that take iodine perhaps will benefit of that iodine ablation. So it's not completely radioiodine refractory disease. A few years ago, there was a lot of excitement about using MAP pathway inhibiting treatment for redifferentiation and making the disease take the iodine again. Unfortunately, follow-up studies were not that promising. So that's why now it's the jury's out about this protocol. The ATA says that only if we have targetable mutation, this should be tried under clinical trials, though. Otherwise, no targetable mutation, this approach is discouraged. External beam radiation is something we consider if those patients are not surgical resectable, if they have not resectable disease, or after the surgery, if there is gross invasion, there is gross disease left behind, then external beam radiation could be applied. It has high comorbidity though, so it's less and less we are doing it. This is an example of old man. As you can see, he had significant residual disease, narrowing the trachea, causing significant stridor. At that time, lenvatinib, TKI, was not approved by the insurance, so he had the external beam radiation, and it helped, as you can see, the disease to shrink in size on the follow-up few months later. Image-guided techniques. This is getting more popular, at least in our institution. We're using it more often. It's what's nice about it. It is local anesthesia. It doesn't require general anesthesia, and with reasonable outcomes. So when it should be considered, when surgery is not feasible or refused by the patient, or already tried but failed. And this sort of treatment should be considered only if we are dealing with single met or just few less than 5. If they're more than that, then definitely this patient will better to have surgery. It can be applied on neck disease if the even if let's say a patient has neck as well as distant mets, but the distant mets are stable, then it can be applied on the neck disease to delay the need to initiate systemic treatment. So this is an example. An older man was reoccurring exactly in the same location in left thyroid bed for the third time within 2 years. As you can see here, there are 2 hypoechoic rounded lesions proven on biopsy to be recurrent cancer. The surgeon took him to the OR for the third time, but unfortunately, the third time he could not find those lymph nodes because of how fibrotic the left thyroid bed compartment was, and that was a good candidate for the local treatment. So we did RFA, a microwave ablation, and as you can see, 3 months later, the results were so impressive, almost those lesions gone. Systemic treatment, TKI should be considered if we are dealing with very rapidly progressive disease within 12 months. It could be also applied as new adjuvant therapy to shrink the tumor and then make it resectable. Better if we have mutation analysis done beforehand. So this way we give the targetable treatment rather than just empiric. And immunotherapy has some role. There is another talk about it, so I will not go into details of immunotherapy. Few words about distant mets. Not very common, luckily, when it comes to thyroid cancer, but not uncommon. Up to 20% of the patients, they will have distant mets, mostly in the lungs as well as bones, less commonly in other locations. The bone mets have comorbidities, as they can cause fractures and can cause pain. The lung mets are the ones that can cause death because of respiratory failure. Active surveillance is very appropriate even in settings of distant mets, as long as they are stable, asymptomatic, and as long as they are not in the brain. So lung mets, when we talk about miliary pattern disease in the lungs or microscopic disease that's taking iodine, this is the only exception where you could consider really doing the iodine ablation every 6 to 12 months until you see no iodine uptake at all in the lungs, because there will be good chance of cure in this scenario. Compared to macroscopic disease, it's extremely unlikely for those patients to go into remission. So I would watch those patients rather than keep hitting them with iodine ablation. Active surveillance, as long as those stable, very reasonable. And in selected cases, we could consider surgery. Let's say if we have single met is growing, the other mets are not, we could do wedge resection or SBRT in that single met that's growing. And TKI when, of course, there is significant progression in the lung mets. This is an example of a young patient going of the lung mets. She has many of them in since 2021, and we have been doing this just basically active surveillance of this non-iodine avid disease, and I'm showing the videos 3 years interval between 2021 and 2024. I saw her in 2026, and the disease is still stable. The thyroglobulin is still around 400, 450. I didn't have the images of the 2026 because done at other institution. That's why I'm showing the 2021 and 2024. Bone mets, the treatment with iodine ablation can provide symptomatic benefit, decrease the pain, but not curative usually. active surveillance is reasonable as long as the disease is stable and not symptomatic. If symptomatic, usually we do external beam radiation. It helps the pain significantly. And we can consider in those cases anti-resorptive therapy like denosumab or zoldric acid. It helps to decrease the skeletal events occurrence in those patients, even though it doesn't impact the overall survival. If we do it, it's important not to do it very often. Just every 3 months is sufficient. Doing it every month, like other cancers, it's too much for thyroid cancer that follows usually indolent course, and it can cause the long-term on the long run, it can cause the potential harms that we know about those anti-resorptive medications. TKI, of course, if there is significant progression in multiple mets. For brain mets, it's different from the lung and bones in the sense that there is no role for active surveillance because of the sensitivity of the location of those mets. So normally, always there is intervention. If it's single met, it's very reasonable to proceed with surgery if it is possible and feasible. If not, then external beam radiation plus minus iodine ablation. And if that's done, then we should consider doing giving the patient steroids to decrease the edema effect and the radiation-induced inflammatory response that happens with external beam radiation as well as the iodine ablation. So in summary, the decision regarding management of recurrent thyroid cancer is best derived from MDT, plus discussing the all options with the patient and making a decision together with the patient as well as their families. There is no one size fits all, and it's better to refer those patients to highly experienced centers that deal with thyroid cancer frequently when it comes to recurrence. And with that, I end, and I thank you very much for listening, and I will be happy to take any questions.